Hi, thanks for joining me at Student Nurses Success. This video is going to cover some of the musculoskeletal disorders. Now, these are not going to cover any motor neuromuscular disorders, so we do have a separate video for that. Remember, you can find a link to the maps in the comments section. Let's go ahead and get started. I'd like to first start with trauma. We're talking about trauma. Soft tissue injuries are fairly common. Soft tissue injuries can occur in the joint capsule, and that can include either subluxation or dislocation. Subluxation would be like a partial, where the joint kind of slips a little bit but doesn't completely dislocate. Sometimes they'll pop back in, or it can be a complete dislocation where you'd have like decreased range of motion and pain related to it. Remember, with any joint capsule injuries, we do worry about blood supply being compromised to the area. Now, a strain has to do with tendons or muscles stretching or tearing. Remember, tendons connect muscle to bone, whereas a sprain has to do with a ligament issue, and ligaments connect bone to bone. So you can have a stretch or a tear of the ligament, and that would be a sprain. Now let's talk a little bit about fractures. There are different types of fractures, and you should know how to discuss these using the common terminology. A transverse fracture means that it's straight across. A spiral fracture means that a twisting motion. And actually, up here, this particular picture could be a spiral or it could be an oblique. It's kind of hard to tell with a one or two-dimensional picture. A longitudinal fracture would go down the bone. An oblique fracture would go across. So again, this one up here, this looks a little oblique, or it could be spiral in nature. It's kind of hard to tell with that picture. Impacted means that the two pieces of bone are actually pushed together. A comminuted fracture is this one right here, where there's more than one piece. An avulsion fracture is really where the ligament rips off a chunk of the bone. So it's not really a true fracture where the bone is broken in half, but it does rip a piece of the bone off where the ligament was. The ligament was actually stronger than the bone. A stick fracture is an incomplete fracture, and this kind of shows that there where you don't really, it doesn't go all the way through the bone, but there's definitely a fracture there. And then a stress fracture is where you do have some injury to the bone, but it's not as much as a green stick fracture. Now, when we talk about the extent of a fracture, fractures can be displaced, meaning they're not lining up. And so this picture here kind of shows two bones not lining up, or they can be non-displaced, meaning that they're nice and lined up. So the two pieces are in a row. Certainly a non-displaced fracture is easier to repair and mend. A displaced needs to be either pinned or maybe plates or needs some type of manipulation. An open or compound fracture is sticks through the skin. And so we see this here where this fracture is breaking through. This leads us to increased risk of infection, and it's going to be a lot more difficult of a fracture to repair. A closed, simple fracture would be one that does not go through the skin. As far as how do you know you have a fracture, there could be any one or more of the following: unnatural alignment, so the limb is not in a line, swelling, pain, and the pain is usually at the site of the fracture. We call that point tenderness, muscle spasms, bruising, because when the bone is broken, it does release some of the bone marrow components. So we see bruising from that trauma as well as other traumas. Impaired sensation and oops, I have bruising twice there. So also for manifestations, you want to make sure you check for your pulses and check for circulation to make sure that it's not been compromised once there is a fracture. Healing, what happens with healing is that osteoclast and blasts form at the site of the fracture and form a callus. And you can actually see this callus on the x-ray, and it starts this remodeling of the bone tissue. And you can kind of see this on the x-ray where you have an increased calcification line where the fracture was, and the healing is going on. Healing can take anywhere from about 4 to 6 weeks, depending on the age, situation, and the nutritional status of the host. Complications of a fracture, one would be compartment syndrome. Compartment syndrome is when there's so much swelling that this swelling has really started to impact the soft tissues and is pressing against the blood vessels, decreasing blood flow through the extremity. A lot of times with compartment syndrome, we see it when we put a cast on. When you put a hard cast on, swelling has no place to go. So swelling then goes in and compresses the blood vessels and will compromise blood flow to the extremity. So we do want to make sure that we remove that cast or relieve that pressure if possible. Early signs of compartment syndrome include tingling, numbness, weak pulses, pale skin. Obviously, late signs would be no pulses, blue extremities, no feeling. You can also have a malunion where the bone does heals in a non-alignment, meaning that the two edges are not approximated and the bone heals. Often that needs to be rebroken and healed together, unless it's a very tiny bone, such as like a like tiny toe or your tiny pinky finger, or it's at the discretion of how much that this misalignment has is impacting the individual. A non-union means that it's not healed after 4 to 6 months. Certainly, we don't always just let it go that long. After about 4 to 6 weeks, they may give it a little bit more time, up to maybe 3 months. After that period of time, they may start with pinning or plates in order to kind of support that healing. We know that smoking, decreased circulation through the extremity, and infection all are going to contribute to non-healing of the bone. Osteomyelitis is a bone infection. We have a separate section. We're going to talk about that in a moment. Osteonecrosis can also be a complication of a bone fracture. And that's when you have bone death because you have decreased blood supply to that area and the bone starts to actually die. Bone is living, it's constantly kind of increasing its density and reabsorbing and making new bone formations. So if you don't have good supply, then it can die. And then our other complication is a DVT, or a deep vein thrombosis, that if it breaks off can lead to an emboli, usually a pulmonary emboli. We see this more common with large bone fractures, maybe like femur fractures. Or if the patient is immobile for an extended period of time, then we know that that immobility causes stasis of blood flow and you can develop a clot. Patients may be on anticoagulant therapy, if they can get up and start moving around, that would be helpful. So we should always monitor for DVT and pulmonary emboli. Let's move over to infections and kind of talk about those. When we're talking about infections, osteomyelitis is the term for infection of the bone. And osteomyelitis can be from two different etiologies or two different processes. One can be hematogenous, which means that the infection is circulating in the bloodstream or it's in another part of the body and it's circling around and it somehow lands in the bone. That's can happen if you have like urosepsis or some other type of sepsis, and you can develop osteomyelitis that way. It can also happen from a direct infection, meaning you actually get the bacteria in the bone directly from either an open wound or a penetrating wound, or perhaps even a surgical wound. In those cases, most frequently we see Staph aureus as the causative agent. So let's talk a little bit about the patho behind what goes on in osteomyelitis. Once you get bacteria growing inside the bone is kind of a closed area. And so pressure starts to really increase, and you get, an abscess that forms or a pocket of infection. And we got a little picture here where maybe we had this infection and then we got this pocket of infection that develops. But if you think about it, bone is hard, and this outer coat covering of the bone is the periosteum. And what's going to happen is it's going to really put a lot of pressure on the bone, cause a lot of pain, and eventually it can actually strip the periosteum away from the bone. It can cause bone necrosis as well. Manifestations of osteomyelitis include redness, warmth, and fever, increased white blood cell count, pain, tenderness, positive blood cultures, and an increase in the sedimentation rate. You may not have all of them, but you certainly could have a variety of these symptoms. Osteomyelitis is very painful. It takes a while to treat. It may take 4 to 6 weeks of antibiotics to treat, may require IV antibiotics, may require surgery to go in and remove that abscess, maybe a drain to leave that open. So it certainly can become quite serious. While we're on the topic of infection, we will talk a little bit about joint prosthesis infection. This would be if you had a joint replacement. Let's say you had a knee replacement, they put in a knee prosthesis. That prosthesis can get infected. If those joint prostheses get infected, we really it's really a long course for the patient. They have to actually go in and remove the prosthesis. They'll put a spacer in there. They'll treat them with antibiotics for several weeks, and then they have to restart that whole process of joint replacement again. So this can go on for months. So we do want to be really careful about good aseptic care when we are taking care of our patients who are post-operative for a knee, hip, or other type of joint replacement. Let's move on down to some other disorders before we get over to arthritis. I'd like to talk about osteoporosis. Osteoporosis is weakening of the bones from decreased bone density. The cause is often decreased calcium. As we get older, we have, if we're men, we have decreased testosterone. Women have decreased estrogen once they hit menopause. And this really starts to accelerate osteoporosis. We do think of it more prominent in women. However, it is something that can happen in men as well. Um, the loss of estrogen with menopause generally impacts women a little bit sooner. Men still make some testosterone as they're getting older, although the amounts decrease. Um, we also know that if you have decreased weight bearing status, maybe a sedentary lifestyle, decreased activity, you're not doing strength or resistance types of training, that is also going to increase your risk of osteoporosis. Smoking and medications can also impact bone density as well. What we basically have is bone reabsorption, which is going on all the time in our bodies, is more than bone formation. And so we're just in a losing battle with that. Patients can get what's called a bone density test or a DEXA, and the criteria for osteoporosis would be negative 2.5 or lower. Osteopenia would be just a little bit higher than that, but it means that you're on your way to osteoporosis. When we talk about manifestations, increased risk of fractures, especially vertebral fractures, compression fractures, a lot of back pain with that. We see a decrease in height as those bones start to kind of just compress over time. Some patients get kind of bent over, and we call that a Dowager hump. I've got a little picture over here with somebody kind of with maybe some back pain and kind of bent over with that Dowager's hump. So those are the risks of that. As far as how to treat osteoporosis, we do have some medications that we can give, increasing calcium, physical activity, exercise. Those are all very helpful. Osteosarcoma is a bone cancer. It's the only one we're going to talk about. Osteosarcoma is a bone cancer, in particular, is more common in adolescents during the growth spurt. And so that doesn't seem unusual as you're heading into your growth spurt. What we see with patients is that they are somewhere about the age of 12 to 18 years old. And while they're undergoing that growth spurt, they're doing a lot of bone formation, and sometimes that can turn into a cancerous type of formation. Osteosarcoma more commonly affects the long bones, the humerus, the femur, the tibia, and they tend to be at the site of the epiphyseal plate or the growth plate. So you would see it right there, maybe develop. So it's usually near the joint. And as that bone starts to grow and gets larger, it starts to decrease the range of motion in that joint, and you would think the bone would be stronger because it's thicker and has a tumor in there, but it's actually increased risk of it fracturing and breaking. And so sometimes they present with fractures. We can do limb sparing procedures if possible, where we actually will remove the bone and put some type of spacer in there. And certainly they would have some chemo and possibly some radiation. Let's move over and we'll do some scoliosis here. For scoliosis, it's a curvature of the spine. You can have a C curve and S curve. This one right here is an S curve. A kyphosis, which is kind of more bent over, kind of like our lady over here with the doe wagger hump. And you can also have a lordosis where you're kind of a sway back. As far as the causes of scoliosis, a lot of cases are idiopathic, especially in adolescent females, seem to be a higher risk. They can be congenital, born with it. Certainly, those would be need to be corrected sooner. Or it can also be secondary to neuromuscular diseases such as cerebral palsy, where spasticity of the muscles pulls you one way or the other and creates a scoliosis. In all cases of scoliosis, our big issue here is lung capacity starts to decrease. And so we see a decrease in tidal volume and we see restrictive lung disease with them. So this is why we do uh, try to correct those to help our lung capacity. As far as management, you can do bracing if it's a smaller curve, but bracing has to happen during the growth phase, and it doesn't correct the curve, but it will keep it from getting worse. So you wear it for several years. And you wear it for pretty much all day, 23, 24 hours a day. If that is not desirable way to maybe lifestyle doesn't allow for that, you can wait till skeletal maturity and do surgery if that's possible and do kind of a one-time. It's it's a hard recovery, but you kind of get it done in a few months period of time. And some people do opt to wait, but again, that has to be at skeletal maturity. Let's move over here to our arthritis section. The first arthritis I'd like to talk about is rheumatoid arthritis. The key about rheumatoid arthritis is that it is systemic throughout the whole body. It is autoimmune and it is inflammatory. So I have a picture here. It can be throughout the whole body. It can affect multiple joints in multiple areas. What we think is kind of going on is there's a genetic component. We see it peaking in adulthood, about 30 to 50 years of age. We do see more women than men, which is very typical of our autoimmune diseases. And we think it's some type of triggered response. There's some kind of virus or something that triggers your body to start actually really just destroying your synovial tissue that is in your joints. So it activates your T cells and your B cells, your macrophages, and that just makes this ongoing inflammation in your joint area. The problem is ongoing inflammation will start to cause scar tissue development in those joints over time. Manifestations, stiffness, especially in the morning, joint swelling, redness, warmth throughout the body and multiple joints. You may see the development of these rheumatoid nodules in the joints, joint deformity over time from the synovial inflammation, scar tissue, and it really just does destroy the joints over a period of time. Fatigue, fever, because it is a systemic thing. If we look at our labs, we see positive blood tests, rheumatoid factor, positive ESR, positive C reactive protein. The thing about rheumatoid is that over time, this joint damage is going to also lead to osteoarthritis. So we know that rheumatoid arthritis is going to eventually damage our joints and cause osteoarthritis. However, osteoarthritis is not the same as rheumatoid arthritis, and osteoarthritis does not cause rheumatoid arthritis. But the systemic nature is key here. There is something called juvenile idiopathic arthritis. And that is a chronic inflammatory autoimmune arthritis in children less than 16. It is just like RA, but affects children. So it would be all the same types of manifestations and same types of concerns. Some children, it may resolve by the time they turn into adulthood, and some will have ongoing issues and develop. Just it will continue into their adulthood. And at that point, it's usually treated like rheumatoid arthritis. Rheumatoid arthritis, JIA, can be treated with steroids to decrease inflammation, biologics, and pain control is important. The thing about JIA is those individuals, if they have joint damage, they may be geared up for some early onset of osteoarthritis as well. Let's talk about osteoarthritis. Osteoarthritis is not systemic, and that's important because that makes it different. It is degenerative joint disorder, mostly on your weight-bearing joints or any joint that's overused. Any overused joint. So, for example, let's say you do a lot of sewing or a lot of work with your hands. That wear and tear on those hand joints can develop osteoarthritis in those. So, although we mostly talk about it, our weight-bearing joints, any overused joint can develop osteoarthritis, and it is from wear and tear. So this joint stress and wear, obesity, heavy weight, the cause is not always clear, but we do see increased incidence in those who are heavy and overweight because it just puts more stress on those joints. And in fact, if you do have osteoarthritis and you are overweight, something that can significantly decrease your symptoms is to lose weight if that's possible. What we see is it's a progressive non-inflammatory disease. There's loss of joint space and causes the bone to kind of hit bone on bone over time and develop bone spurs. And I think I have a little picture down here. Um, this picture here, this joint space is decreased. It really should be on an x-ray. You should actually have a big space between this cushion. Um, and what we have in osteoarthritis is that that cushion is lost, and so you get bone on bone, and that causes the development of bone spurs and pain, lost cushion and decreased joint space. So you can actually see it on x-ray. They can just do a simple x-ray and tell that that joint space is collapsed. And we'll also see decreased range of motion. Um, the joints become maybe enlarged from swelling, maybe some noisy crepitus, creaking, cracking of those joints, pain, certainly, stiffness, and you can start to get nodules and bone spurs inside those joint space. As far as what we do is pain control, physical therapy can actually help a lot. Weight loss as well is something that may be helpful, and eventually we may need a joint replacement. Our last arthritis we're going to talk about is gout. or gouty arthritis. Those with gout have a disturbance in uric acid metabolism where they just don't metabolize uric acid well, and they make lots of urate salts that end up in the articular, periarticular, and the subcutaneous tissues. So I have a little picture down here. We get this uric acid buildup inside that joint, and these are like tiny crystals, and that hurts, especially in that joint space. And patients will get recurrent attacks as they get older, they get more of them. It's very interesting. We see it frequently, the pain develop in the big toe, and there's gravity involved with that. It ends up down there. Plus, your big toe is really important for movement. Um, Individuals with gouty arthritis do also seem to be at increased risk for developing kidney stones, and having some renal impairment for that. We see pain, redness, swelling in weight-bearing joints, and again, that great toe is frequently affected. And there you go, a nice summary of the musculoskeletal system. Remember to watch our motor video as well for neuromuscular disorders. Thanks a lot. Remember to like and subscribe, and have a great day.